So I wanted to sum up the studies which were done in the last 2 years regarding the screening possibilities for preeclampsia in second and third trimester. And this is one of the studies from the FMF group, which was carried on between 19 and 24 weeks of pregnancy. And this was a prospective screening with over 120,000 pregnancies. And the performance of screening for preeclampsia was based on requiring delivery before 32 weeks, before 37, or after 37 weeks of pregnancy. And this was a combined screening with maternal history, mean arterial pressure, uterine artery PI levels, and as biochemical markers, SFLT and PLGF. And in this study, it was shown that the mean arterial pressure, uterine artery PIs, and the SFLT levels were significantly higher in the cases of preeclampsia, and the PLGF was lower. And as you can see here, the maternal history alone had a bad performance for detecting or screening for preeclampsia, and the addition of only SFLT in this study did not improve the detection rate. And the performance was high for preeclampsia before 37 weeks, but there was a weak performance for a late-onset preeclampsia after 37 weeks. And the next study that I would like to show you is again from FMF, and this time the same or a similar algorithm was used between 30 to 34 weeks of pregnancy. And this was again a prospective screening in this pregnancy weeks with over 30,000 pregnancies. And the performance of screening was based this time was with preeclampsia requiring delivery before 37 weeks and after 37 weeks. And this was again a combined screening with the history, MAP, uterine artery PIs, PLGF, and SFLT. The results were similar. The SFLT, uterine artery PIs, and mean arterial pressure was higher in the case with preeclampsia, and PLGF was lower. And the history, maternal history alone had a bad performance, and the screening for preeclampsia before 37 weeks was superior to first trimester screening at this time interval of pregnancy. I mean, when we do the screening at 30 to 34 weeks, the screening was better in the performance if you compare it with the first trimester screening. And for late onset preeclampsia after 37 weeks, the performance was still weak. And this was a similar study, this time between 35 to 37 weeks, and the common findings were approved, and screening with these markers could predict the majority of the cases with preeclampsia and small for gestational age. And in this study, the other outcomes like fetal distress, cesarean section, and low cord blood pH levels were also tested, and for predicting these kind of outcomes, this screening was not useful. And the statistical results were almost the same as the ones done for 30 weeks. So what are the pitfalls and the advantages of these models? These are nice large populations, and the accurate measurements were obtained in short time period, and the expression of the values were in moms after adjustments with the maternal characteristics, and there was a bias theorem used to calculate the patient-specific risk, which was also introducing an optimistic bias. And at this time period, there were no management options as proposals of what do we do with these patients after screening them. And could the implementation of these methods improve the perinatal outcome or our daily routine in their practice? And if you want to detect the preeclampsia, how long time do we have after measuring all these biomarkers? And this was shown, as you know, the American College of Obstetricians and Gynecologists have this recommendation that they do not recommend a screening, and they say that the maternal history would be enough. And this is one of the popular publications from Tang. And we know that if we only take the maternal history, we can have a positive predictive value of about 30% for adverse pregnancy outcomes. So the maternal history would be definitely not enough if you want to do a screening. Also as well in second and third trimester. Stefan told yesterday about the other models that they in the Berlin group. I don't want to talk about them so much, to use S-split PLGF ratio with some cutoffs. And there are also some studies trying to do repetitive measurements to see if that would be a good method to follow up these patients as well. And this is the consensus statement published 2 years ago and 1 year ago in German as well. To show the general opinion after all these trials and publications. And it was advised that the large populations are still needed to validate all these studies, and the prospective studies were needed as well. And in many of these cases or the studies, only one single platform was tested, and the other platforms should be tested as well. And the new methods should be combined with other well-established methods, and their screening performance is also yet not tested. And in many of the studies, only the high-risk populations were involved, which was also one of the major points in this consensus. And if you would like to read this consensus statement, there are also other recommendations about the management. So with this background, we tried to think of a study, and we conducted this study in the University of Essen in Germany, and we started a prospective study for us to have a screening population between 28 to 40 weeks of pregnancy over 2 years of time with more than 200 patients. And our questions was if we want to have a screening population, would S-split PLGF or their ratio be effective? How would be the cutoff values in our population? And do we need MOM values or the raw values? How would they be the effect of them? And the outcome measures were preeclampsia and IUGR. Intrauterine death was one of our outcomes, but in that period we had only one case, and that was not enough to do the statistical measurements. And we wanted to do the measurements with the Crypter machine. And this was my slide from last year, which I promised to have the results by early 2017, and we have the results. And we wanted to have a population that were coming routinely in their first visit at the hospital at the third trimester with no signs of preeclampsia or IUGR at that time. And we conducted the study between November 2013 and April 2016. And in total, we had 903 patients. 78 of them had to be excluded afterwards. The people who were involved taking the blood were blinded. That's why we had to exclude the twins or chromosome problems afterwards. And in 10 patients, we had no outcome. And there were 4 patients with chronic diseases like liver transplantation, and 2 patients had early onset preeclampsia. So in total, we had 825 patients, and 32 of them had a late onset preeclampsia. We had 676 controls and 22 patients with IUGR. If we take the birth weight under the 10th percentile, it was in fact 82 patients, but then we wanted to have the 5th centile, and also with at least one pathological Doppler measurement, that would be the umbilical PI over the 95th centile, and that was in total 22 patients. These are the patient characteristics. We had FGR about 2.7% in our population, and late onset preeclampsia in 3.9% of the patients. And the average age was 32, and as you can see, in preeclampsia, the BMI was much higher. So we wanted to check and control, first of all, the S-fillet. You can see the box plots here. The S-fillet levels were in IUGR, preeclampsia, and pregnancy-induced hypertension, statistically higher in comparison to the controls. And this is our scatter, and we did have a cutoff of 20,000 for S-split. And we did a linear regression analysis. We adjusted the measurements for maternal age, week of pregnancy at the time of blood draw, and BMI of the patients. And we had statistical significant results for S-split in preeclampsia and IUGR. These are similar results for PLGF, but other way around. The PLGF levels were lower in preeclampsia and IUGR in comparison to the controls. And we did a cutoff of 1,5. And the linear regression analysis showed significant results for both of the pregnancy complications. And we did also the same measurement for S-split-PLGF ratio, and you can see our significant results in preeclampsia and IUGR. We wanted to check PAP-A as well. It is, it's as first trimester, very important, and I wanted to see if PAP-A would do a good effect for screening purposes at third trimester of pregnancy, and the performance was not so high as S-split and PLGF, and for IUGR it was not statistically significant. And we wanted to try a new marker, which is MR-POINP, to see if MR-POINP would have any effect in the screening. It is natriuretic peptide, and it is secreted from the heart, and it is in the last years a common marker in cardiology to see if the heart performance is good or bad, and if they have right-sided heart failure, the levels are high. And last year in this platform, we heard from Baski about the pathophysiology of preeclampsia, that maybe the heart could also play a role in late-onset preeclampsia, and we wanted to check a new heart marker if it would have any effect in our measurements. And for MR-POINP with preeclampsia and IUGR, we have seen the significant results. And we did also a logistic regression analysis for preeclampsia, and the results were significant for all the markers and the ratio. And the ROC analysis for preeclampsia shows these results. If you see S-split-PLGF ratio, in our population, we had a cutoff of 57, and it showed a sensitivity of 84% and a specificity of 93. And I think in this slide it's also very important to see that the S-split and PLGF alone, with their own cutoffs, had a similar sensitivity and specificity as the ratio. And the AUC for S-split-PLGA ratio in our population was 0,929. And we did a logistic regression analysis for IUGR as well. And the PAP-A in this analysis was not significant. And the ROC for IUGR is as seen. For S-split and PLGF ratio, we had a threshold of 63.6, and it showed a sensitivity of 50% and a specificity of 93.9. And the ratio for IUGR showed an AUC of 0.7, and with this new marker, MR-POINP, we also achieved an AUC of 0.71. And after the publication of the cutoff of 38 to exclude preeclampsia for 1 week, we wanted to see this cutoff in our population and to check the performance, and we achieved a sensitivity of 37.6% and a specificity of 85.9. And it was other way around, I'm sorry. This is one slide from the latest publication of Professor Nicolaides. He wanted to propose a management after doing a screening. If we want to screen them as well in the third trimester, we should propose a management, a clinical management as well. And I do advocate this idea as well, that if we have a high-risk population after a screening, we can offer them an intensive clinical management to check on them, for example, in a weekly basis. And I find this publication also very important. This is my last slide. And they did compare in FMF the screening for preeclampsia at 31 to 34 weeks with SFID-PLGF ratio and the combined screening. And for preeclampsia before 37 weeks, they had an AUC of 0.98 only with SFID-PLGF ratio, and again AUC of 0.98 with the combined screening, and the results were similar. Thank you.